Hello, and welcome to another segment of Intersections, Policy, Program, and Practice Exchange. My name is Elisa Gwilliam, and today I have the pleasure to be speaking to Executive Director of Mental Health America, Duchess, Andrew O'Grady, Professor of Psychology and Director of the Center of Aging and Disability Policy at Mount St. Mary College and co-founder of NOAR, the National Organization of Adult Addiction and Recovery, Dr. Larry Force. And our special guest today is Paul Gionfriddo, President and CEO of Mental Health America. And I'm glad that you're all here today. And as our topic is looking at mental health on a national level. And Larry, do you want to get us started?
I do. Alyssa, thank you so much for facilitating this in the way that you facilitated. And Andrew, I think, as we were talking, as we were coming up to going, live, that this is our 10th episode. And what we had only hoped for, I think we have been able to really hit the ball out of the park, so to speak. And that is to be able to elevate the discussion about addictions, recovery, and mental health on a national level. And Paul, it's an honor to have you join us today.
Thank you.
It's what we could only have hoped for, that when we're talking about policy issues, that we have the voice of a national organization, sitting side by side with us. So with that, I'd like to turn it over to Andrew for the introduction.
Yeah, I'm very excited to that Paul is joining us. When we talked about who we would have on this show, I obviously thought of Paul because we wanted to, as Larry said, go local and widen it out and be national. And if you don't know, if you're watching this, MHA, Mental Health America, has a national organization that Paul is the CEO of. And then there are affiliates throughout the country. And most states have an affiliate at their state capital who, like Mental Health America, that Paul oversees down in Washington, focuses on policy and focuses on moving the needle on how mental health is dealt with in the legislature. So then there are counties throughout the country, like Dutchess County, New York, where there are MHAs. And in New York State, we have quite a few MHAs. In fact, going up the Hudson River region, every county has one. And we are the provider of services. And we feed our staff to the state and the national affiliate to assist with lobbying and so forth. But they are the affiliates. They are the focal point of policy. And we have dealt with interviewing people who have gone through recovery. We've dealt with talking to people who provide services. And we have spoken to Marcus Molinaro, our county executive, about his take on how things can be better and how he does things. And now we have Paul. And Paul, I'm really happy that as leader of our national organization, that you're here and that you can kind of help us have this discussion and talk about, where we are now, where we were 10 years ago, and hopefully where we're going. We have managed care as a big issue. I know in New York State, I'm sure nationwide, the budgets are huge problems right now with COVID. And, we have a lot of challenges, but at the same time, there's a lot of opportunity. And we'll talk probably a little bit about the technology and how that becomes an opportunity and how we're using this platform and to reach people throughout the country, not just locally, through technology. So where there's trouble on the horizon, there's always opportunity, and we try to look for that. So Paul, I want to thank you for being here, and maybe you could just introduce yourself. And you have an interesting past. Past you were in Connecticut. As a politician, as a leader there, and then you did a lot of not-for-profit work, and here you are running this great organization.
Yeah, and I can start with the where we are, and the where I am is actually only about 50 miles away from you, because my home is in Middletown, Connecticut, and since the start of the pandemic, really for the last 6 months at Mental Health America, we've been working remotely. So I've been doing all of my work out of Middletown, Connecticut, even though our office is in the DC area in Alexandria, Virginia. And it certainly has been an interesting time. I mean, from the days I was in the Connecticut State Legislature, which is now 42 years ago, is when I was elected at first. So nearly a half century ago, we never would have imagined that this would be the time we'd be living in, and these would be the challenges that we would be dealing with at this time in our lives. And yet, and I'm sure we can go into this, I think they present certain opportunities, and notwithstanding the irony of the fact that physically, I've never been very far removed from Dutchess County during my time in either the state legislature or more recently living in Connecticut. But it's through the miracle of technology we're actually able to draw ourselves even more closely together, and including people who are literally living in across national lines. So I'm looking forward to having this conversation. I'll say one other thing about, like a lot of people, I wasn't trained to deal with mental health issues at all. I was a philosophy major in college and ran for the state legislature shortly after I graduated. And when I got elected, was assigned health to do because nobody else wanted to do health at that time in state legislatures. And imagine that was only 10 or so years after Medicare and Medicaid were created. And so, I had to learn on the job a lot about mental health, and then learned on the job further when my son Tim developed schizophrenia around the age of 5. And Tim is now in his mid-30s, has been living with it for a long time. So for me, like a lot of people, my experience in this field comes about primarily because of it being thrust upon me as opposed to something I initially sought out.
Changes your life, and it leads you to want to get behind it and do everything we can to change, because you must have experienced firsthand the difficulty, and we still deal with it, the difficulty accessing care and dealing with insurance companies and waiting forever for an appointment, and then the whole, which we reference often, the whole I want to say the opposite of patient-centered care, the punitive aspects to mental health and addiction care that we still deal with today, that is nothing like any other disease or disorder. We have to comply. We have to, do all these things that others would not have to do if they had a heart condition or something else. So firsthand dealing with that certainly opens your eyes, and I guess, gets you to gravitate toward this work. So there's a positive that comes out of a negative.
Positive, I guess. Yeah, no, it was a surprise to me when I'd been doing this policy work for 10 years. And then, Timothy started having the mental health issues that he had when he was very young. And, here I was in Connecticut. I was running the public health committee. I was running the appropriations subcommittee that dealt with all health matters. I knew pretty much everybody in the state of Connecticut at that time. It's around 1990. And had every connection imaginable. And yet when my son entered into a period of crisis with his mental health condition, really had very little idea or to know how to deal with this. I mean, even those of us who were connected, found that, he starts getting expelled from school, suspended from school. He's, tough to get him appointments to see people. It was tough to get a diagnosis. It took 10 years to get the diagnosis, even though we were, going round and round about it for a long time. It was tough to find a child psychiatrist, a child psychologist. I mean, it just overwhelms people. It overwhelmed people then. And, from the stories that I hear when I tell my own story, it's still overwhelming people today to a very great extent. You put your finger on it with the punitive nature of this. Imagine, I was, thinking about making policy during a time of deinstitutionalization in the 1980s, not recognizing at the time that what we were doing effectively was going to be reinstitutionalizing people in jails and prisons. And so the custodial care wards we closed down are in some respects, again, not very far from you at the western edge of Connecticut, is where we have our the old state hospital ground, part of which was converted to a prison so that they could have a unit for people with serious mental health conditions. And Tim was in that unit at one point, and in that prison at one point. And it's just, you're right. I mean, cancer, we don't talk about cancer late stages this way. Heart disease, we're all about trying to help people prevent and then early identify and stay healthy. And compliance issues and failures as treatment failures, things like all the language is really built around a different concept than the rest of healthcare delivery and the rest of health delivery. And it's time, for people to embrace the work you're doing and others are doing to change that.
I always say that we have a walk for awareness for mental health and addiction, and we get I don't know 200 people to walk across this big walkway we have in Dutchess County, and then there's a breast cancer awareness walk, and thousands and thousands and thousands of people are there wearing their pink, and thankfully people recover from breast cancer, and thankfully I'm happy that there's attention to it. Except that the people that recover from breast cancer, they did it for a couple of reasons. One, the medication worked, thankfully, the radiation worked, whatever surgery they had worked. And then secondly, they are surrounded by people. I have friends who had cancer, and what do? We cook food, we bring it over, we call, we check, we do all this stuff. And that goes a lot toward healing. But it's based on those external things, and then once you're healed from it, you have to hope it doesn't come back, and you have little or no control. And then we have people with addiction that fall that we want to have a walk for them. There should be twice as many people walking over that bridge, cheering people on that are in recovery, cheering them on, patting them on the back, reinforcing that they're doing a great job, and it doesn't happen. And it's sad, and same with the mental health stuff. It's really, we need more cheerleaders. We need more families to stay together and be supportive. And, I think we're moving there, but it's so slow. It's like a turtle.
Yeah, I agree with you. One of the things that I've had the, horrible experience of living through as a parent was the death of my adult daughter a couple years ago. And Larissa was diagnosed with metastatic breast cancer at the age of 30 and lived for 2 years with that. And I've often, and during that time, and Larissa would do this as well, drew the connection between the experience we had with her stage 4 breast cancer, and with Tim with his effective stage 4 schizophrenia that he has, and the differences in the way people react to and respond to those two conditions that way, with two young adults who were living with these. And Larissa got just a whole variety of support, GoFundMe accounts that people donated thousands of dollars to for her, wonderful opportunities to go on national television and talk about living with metastatic breast cancer, and the support of her favorite entertainer, Mariah Carey, who did so much to help make Larissa's last couple of years happy ones and pleasant ones. And then Tim, meanwhile, nobody ever made a donation to Tim. Nobody ever said, oh, let's do a GoFundMe page for this guy living out on the streets of San Francisco homeless. And nobody sees these things the same way. And with addiction, I think, it's just as complex, and sometimes, as you say, even worse. I mean, Tim has self-medicated during his time with schizophrenia, and whenever his diagnoses have tended towards substance use disorder, it's been a real struggle to have people, not blame him, right? And that's where they go. Even, it took us years to convince people not to blame him for his schizophrenia. Man, try to get people not to blame people for having a substance use disorder. Why can't you just stop? Like people with depression, why can't you just pick yourself up from under it? Nobody ever said to Larissa, thank God, why can't you just, ignore that cancer? Why can't you just clear it, yourself? Because it doesn't happen that way. And, Timothy and Larissa spoke only once during the time Larissa was ill, because again, Tim has been mostly homeless, but I was able to have them be in a room at one time with the phone when, Tim called and I was with Larissa, and they spoke for about 15 or 20 minutes. And what was so clear was that the two people who got it were Tim and Larissa, right? Where at the end of that conversation, Larissa, who was dying of cancer, said to me, I just can't imagine what Tim is going through and how difficult this must be for him. And I never understood that when I was a child and he was sick, but I understand it now. And Tim saying the same thing, supposedly people with schizophrenia lack empathy, not Tim. He said, I just can't imagine what Larissa's going through right now and how difficult this must be for her. So maybe we need to listen, pay attention and change the way we think about these things.
There have been so many things that you've said in such a short period of time that resonate. Alyssa, do you have the ability to bring up that picture? So here is a picture of a psychiatric center that's in our community. Or should I say was in our community. So I'm driving down Route 9, which is a main thoroughfare in June, and this catches my eye. And I had worked for the state for over 20 years in different institutions. So I turn around and I get out of the car and I take this picture. And we've used this now as a reference point for our discussions. Because these institutions in New York, like Connecticut, were built, 90 miles away from metropolitan areas, hidden. And at one point, there were close to 5,000 people that lived there. So Andrew and I have talked about this. I mean, he's a big advocate for, destroy the silos, get rid of the silos, mental health, addiction, get rid of the silos, treat the person as a person. But as we know from a policy perspective, the pendulum either swings one way too far or the other way too far. So the idea of deinstitutionalization. I have a dear friend, Roger Monti, who I was looking for the essay that he wrote because he took the two words, community and institutionalization, and blended them together. And he wrote an essay about the community installation of it, however he pronounces it. But what he really means is, we've torn down those walls. We're tearing this down, but we're building little kingdoms and little fiefdoms in the community. I'm always taken by agencies. When I worked for the state, one of the things that I would recommend that deputy commissioners would do in conversation is say no. And what was the question? Could one agency have an increase in their budget? Why not have the two agencies try to work together, to go over, the boundary lines? You might have one agency that will go unnamed that was well-heeled, and they had group homes. And around the corner, there was another agency that did not have the same type of resources, but that well-heeled agency wasn't sharing, staff or resources. It was like everybody had to have a director, everybody had to have a board, everybody had to have a direct budget line. Why are we not trying to figure out how to blend these things together? So the tagline that we have here is mental health at its best, the tearing down of walls. And then recently we've started to reference, which is a great, opposite approach, is the picture of your bell that Alyssa will be able to bring up. And it's the blending. I come from trained in behavioral, psychoanalytic, as you're traveling through your studies, you end up with different paradigms. And now I land and so happy in the solution focused, where we're not distracted by diagnoses. We're looking at the person. As I tell my students, and Alyssa and Andrew have heard this over and over again, bring two things into a family's life, your heart and an awareness of technology. But the first thing you bring is your heart. And you say that you weren't trained in mental health. On a personal level, I have two kids too. My youngest kid a year ago ended up getting a spinal cord injury. I was not prepared for that as a result of a diving accident. And what I say to him, and I say to you, and I hear you saying it back to us, is that he was built for that moment, for this moment, because he's strong and he's determined. And we were built for this moment because we know how to access systems. But when somebody calls me, and that's what I wanted to lead up to ask you specifically, when somebody calls me and tells me how I should feel now that I'm in this world, it's a nice call and I thank them. But when a family member calls me, I was on the phone the other night with somebody who was exactly where we were a year ago. And I spent 2 hours into the wee hours of the morning talking to him because I wanted to be able to pass on to him what was, but that family connection, that lived experience, it resonates so completely differently. So as you're going through this, I mean, you never thought years ago when you're sitting in Connecticut as a legislator that you'd be sitting in Washington, representing, mental health and doing it so well. But what was that? How did you survive? That's the question. How did you make sense out of it? And what are some of the lessons that you've learned that can be passed on nationwide to people that are listening to this? I mean, for me, if somebody asked me that family support of other families rallying around me, understanding me.
Yeah, I was lucky. I at least consider myself to be very lucky to have Tim. And because, I'm not going to, undersell at all how difficult Tim's childhood and it was for all of us and for his siblings, his parents, everybody around him, and also, his young adulthood. But throughout all of that, Tim and I figured out how to be supportive of each other. And so we have interesting and have had very interesting kinds of conversations. I say this because this parent-to-parent piece is really important. And I want to start with that and then maybe move over a little bit to the policy piece of how it informs policy work that I do. A lot of parents, we struggle with this because we want to fix it, right? I wanted to fix Tim. My aspirations for him, were so different, from what he has become, if you will, the circumstances of his life have become. And yet, throughout all of this, when I've been able to take the time to stop and listen to Tim, I find that he informs me about things that really matter to him, and they aren't the things that mattered to me. And so they've, over the course of the last 3 decades, become more important to me. Like that Tim is happy, that he is satisfied with his life, that he is patient. He's taught me patience when my irritation at the system has grown so much. He said, even at times when, months and months would go by, I haven't heard from him, didn't know if he was alive or dead, reach points in my life where I was like reading the obituaries from California newspapers to see, or the news stories to see if unidentified, people had been found. When I would contact him, finally talk to him the next time, months and months later, he would say, "Dad, why are you worried about me? I can take care of myself." And I'm like, okay, take a deep breath, Paul. He was telling you something important, that he is, in his own way, taking care of himself as best he can. Now, I know the numbers, I know the odds. I live with an anxiety disorder, so I don't need anybody to look at this and say, oh, this guy's just in, some kind of magical thinking land here. I know what I worry about every single day, but I also know that. And I've learned to understand that my son can inform me and can inform my thinking, and I can carry that information with me to advocacy work that I do. And so, one of the great strengths of Mental Health America is that we were created, by a young man with lived experience. And it's interesting because Clifford Beers, he's been long gone, but I have a friend who works at Johns Hopkins University and was an undergrad at Wesleyan University here in Middletown in the 1960s, and was doing an internship when he was an undergrad at Connecticut Valley Hospital, which was one of the hospitals that Clifford Beers was hospitalized in 60 years before that. And there were still a couple of staff people there who remembered Clifford Beers from his time at Connecticut Valley Hospital. So just one step removed from this, Clifford Beers was an impassioned, man who had lots of thoughts and wrote prolifically, expressed himself prolifically, and was certainly described in a way by those people as, despite having significant mental health concerns, a man of a great drive and passion and ambition. And so just maybe not the kind that his family, expected. So, going into DC and saying, okay, there's a great American Psychiatric Association, a great American Psychological Association. There's a great, National Alliance on Mental Illness that represents a lot of the families involved. There's a great National Council for Behavioral Health that represents a lot of nonprofit and safety net providers. There's the NASHPID, which represents the mental health directors in the states and all the services they provide. But who do we represent? We represent Tim. We represent people who can help inform us to inform the system about building it around not the needs of the providers, but the needs of the individuals. So we come full circle round to me understanding that, the system, the problem we've had in the system that we've built in the entire time I've been active in policy is that we have all too frequently built it around the needs of providers and payers. And we've all too infrequently built it up from what people need and would need for independence and define as their own needs for independence. And just making sure that we keep thinking about that so that we get balance in the system. Because as I like to say, whenever a clinician's meeting with an individual with a serious mental health condition, there are two experts in the room. The clinician's got information and experience that's a mile wide, but a foot deep about this individual who they may be seeing for the first time. The individual has information that's a foot wide because they're in their own heads, but it's a mile deep. And when we can put those two things together, I think we can build much better systems that won't fall into the same disrepair that our systems of the 60s and 70s have fallen into, the aborted attempts at community-based service delivery that we stopped basically in the 1980s, and this failed system of incarcerating people in jails and prisons primarily because of their mental health status.
Yeah.
I refer to it as the phantom system, the phantom community-based system. When you're talking, I'm thinking about, in the arena that I came from, we talked about self-directed opportunities, self-determination, but I'm not sure if we've completely have bought into that. I think we talk that, but self-determination really means, how would you feel, not just you, but any of us, if we came home and there was a white county car sitting in our driveway, peering in from a public agency perspective to our private lives, telling us what we should be doing? There are so many times that, and I tell this to the students all the time, do not capture your client. Do not. Because we ask clients to do things that we don't do ourselves. And because we have the agency and the power of agency, it can be a very uncomfortable situation.
There are so many examples. There's so many examples of that. People, I talk to our staff all the time about judgment. Don't make judgment calls on people. Allow them to be who they are. You walk into somebody's apartment and it doesn't look like you think it should be. It's not your job to make them, comply or fit into your square box. And we do that all the time in the system, all the time.
I'm teaching a theories of social casework course in the fall now. And one of the things I had the students do as their first project is do a genogram of their own family, because I want to give them the experience of what it feels like, because this is what we do as a system. Tell me about your family. And then we sit back and we take notes. It's not easy talking about families. We all have families. We all have stuff. And to the point that Andrew makes, we're not there to fix people or make them look like our families. But I want to circle back on one thing. You talked about, the way that it was, and now here we are. Well, here we are surrounded by technology, and here we are in a new world with new mannerisms, new guidelines, the COVID world. One of the things we have stressed, and I think we've done a really good job at it, is that, and somebody didn't correct me, but they gave me an insight that I hadn't really thought about, because I said, recovery can be isolated. They said, no, recovery is not isolated. Addiction is isolated. Recovery is done, you know, within fellowship for some, within, you know, some other type of group support for others. But here we are. And one of the themes that we have really tried to amplify is the fact that even during these times, you don't have to do this alone. I mean, although that, you know, everybody's working remotely, we're still present. So maybe you could talk a little bit about, you know, with the use of technology and now in this COVID world, how is that impacting your message, your operation in today, you know, for today?
Yeah, and you know, some people will, you know, immediately think about this in a narrow way, and it's important to at least take note of the fact that in the last few months, the opportunities to get care and services virtually have just expanded dramatically because of the pandemic. And so people who may take that or interpret that question narrowly, you know, I just want to make sure that we note that for them, wherever they may be watching this or listening to it. But for us, you know, we have really seen an incredible increase in the number of people we have been able to reach because of the tools that we use. Let me just give you one example of one program, our online mental health screening program, where we offer, you know, 10 validated screens. They're among the most common screening tools used by clinicians in the country too. For depression, it would be called the PHQ-9. For anxiety, the GAD-7. And people can freely come to our website and anonymously screen and get a result, and then get some advice about what to do with this information that you get. All, by the way, based on what screeners have told us they want, which is 4 things. They want not just referrals to care and treatment, but more frequently even, they just want more information. They want do-it-yourself tools, and they want connections to other people who have gone through the same thing they have, a theme we've hit on here too. So you can do a lot of those things now virtually. So we can give them more information if you're not putting it in pamphlets, but you're putting it online, for example, and you can change that information really quickly. You can engage people online with interactive tools that people like. And of course, you can get people connected to peers in ways we never could before. What's happened to us since the start of the pandemic is that we've seen our screening numbers increase dramatically. And I think there are a variety of reasons for that. But just to give you an example, that our general averages had been about 100,000 or so a month. And in April this year, we had about 70,000. In May, that went up over 200,000. And by August, we've just had our biggest month with about 340,000 people who took a screen. So the ability to reach just 1 million people this way in the last 4 months has presented a dramatic opportunity for us to get more information out, and also to understand more about not just how the pandemic is affecting people, but just in various populations, how they are distinctively feeling the effects of depression, let's say, or anxiety, or even psychosis, where we've had hundreds of thousands of people, you know, screened for psychosis now this year. So, but just, you know, one example, and it won't come as a shock to anybody. You know, the 11 to 17-year-old population with suicidal or self-harm thinking on more than half the days of the week is far greater. The percentage of that population, nearly 50%, right around 50% take a screen. Suicidal thinking, this would be a depression screen, down to less than 30% in my age group, you know, over the age of 60. So we're able to see that even the populations we thought were going to be most worried, most depressed about COVID back, you know, 6 months ago, when we said it's basically going to be, you know, abbreviating the lives of older people, and that's who's likely to be most worried about this. From the beginning, we were able to see and understand that 11 to 17-year-olds who were not even thought 6 months ago to be all that much at risk for this immediately saw the increases in anxiety and depression and more serious impacts of anxiety and depression. So that's been useful information for us to get. So the technology's not only enabled us to reach more people, but it's enabled us to absorb so much more information and data that we've been able to really change and amend and abridge and alter our approaches to the way we're talking about this pandemic on the fly.
It's fantastic. That's fantastic. I think that's it really shows, it goes to show that there are opportunities, and you know, those numbers are terribly high, and it's sad. It reflects what I knew just in my small little world in Dutchess County, and even my small world of my own, where I have many more friends and people that know me socially, that I'm the guy that works for mental health, and they call me and they want to know, you know. They're all like, you know, you were when your son was 5 and 6. Like, who do I call? What do I do? And there's a lot more calls like that. So it reflects. It's the same reflection that we see locally, and it's sad. It's sad. But connecting people, and this kind of conversation, people watch this and they want to hear about this stuff. When I write in the paper and you write something, and it's amazing how many people say to me, I would never think they'd read it. You know, I read your thing you see something about mental health, people are curious. They're not just curious because it's something foreign to them. They're curious because they know someone in their life, either themselves or someone in their family, who is struggling with this. And people can't get enough of this conversation so they can be better informed. And here we are doing this, which is going to go out nationally. And it's just a conversation. It's a conversation about, you know, how things are going. You put some very personal stuff out there, Larry, as well. And it's beautiful. And I think the more people are real, the more people realize that there's others like them out there. So,
and the overarching theme is you do not have to do this alone. Whether
Right.
it be COVID, non-COVID, whether it be whatever, you do not have to do this alone. Know that there are organizations represented by people with hearts, with lived experiences, that are like, hey, we can be of help. And I think that's, you know, we could all reference clients that we work with. I mean, some clients and family systems are tortured because of the fact that they feel as though that this is it, you know. And one of the things that I talk to the students about is you never leave anyone without a sense of hope. And there is hope. And there are things, and that's not, you know, smoke in the room. That's real. You do not have to do it alone, and everything passes. I mean, I you know, looking back at my own life, there were periods of my own life. Is this it? Is this what, you know, is this it? And then now I'm looking back at it. Is this it? No.
yeah, beautiful.
Yeah, there is hope, and that's you know, a hashtag I use frequently is just the hashtag always hope, and it's actually one my daughter and I started using back and forth when she was sick, and when we wanted to send, you know, Carol Burnett type messages to, you know, a member of the family when we were doing something that was public, we would hashtag it always hope, and know that part of that message was for the other person. So you're absolutely right. There's always hope, and there's hope in these connections, and in knowing and understanding that pretty much everybody is going through this right now in ways many people never expected to have been going through just 6 months ago. You know, even back then, just a few months ago, a lot of times mental illness and serious mental health conditions, you know, were still about some other people. Right? They were other people. They were people, you know, like Tim. Maybe they're homeless people. Maybe they're people ill for a very long time. And, you know, we used to talk about it. Mental Health America, we talk a lot about acting before stage 4, moving upstream and doing early identification, early intervention. And people cast that as being about the worried well for so many years, so many decades. Oh, Mental Health America, they're about the worried well. And, you know, and finally, I think what people are understanding as a result of the pandemic is that we're all worried. You know, and too many of us who were well as a result of the worry are finding that transforming to clinical conditions like anxiety and depression. And so it's hitting not just close to home and not just in the home, but many of these people, I think, in our audiences, as they see this stuff, it's hitting them. And many of them are finally starting to tell us, yeah, me too. It's me personally who's feeling that anxiety now, or feeling like I can't get up out of bed in the morning, and, you know, or feeling the post-traumatic stress that I've had, that this is brought back some other bad things that have happened in my life. And so maybe, when with so many people reporting to the US Census Bureau and so many people reporting to the CDC that their anxiety and depression are real right now, at least half the population is owning up to this right now, clinical symptoms. This is a more opportune time for us to change policy, frankly, than we've had in a very long time. Now, if only our policymakers in Congress could get their act together, the Senate bill before this most recent one, but their last bill and the House bill, both for the first time had substantial dollars in for mental health. They both agreed that we need billions more. It was the first time we were seeing $5 to $10 billion for mental health. But after the election, maybe in a lame duck session, we're going to see a bill move, and I think we're going to see more mental health money in it than we've ever seen before.
Yeah, well, here's the hoping, right?
Here's the hoping.
I hope.
Here's the hoping.
We have to, I'm sure we're wrapping up our 45 minutes. So Elisa.
Absolutely. Well, thank you, Paul, so much for joining us today. And before we wrap up, do you want to give the website address for MHA?
MHAnational.org.
Excellent. Well, thank you very much. And thank you for joining us today. You've been listening to Intersections Policy, Program, and Practice Exchange. And if you want to hear this again or share it with a friend, log on to the Digital Resource Center on our website, www.intersections-exchange.org. And you can also follow us on Facebook, Instagram, and YouTube. We hope you would join us next week as we continue our conversation together.